Good evening. I think we're going to get started. I'm Dr. Alan Wasserman. I'm chairman of the Department of Medicine at the George Washington University, and I'm glad you're all here tonight. This is another one of our sessions in Frontiers in Medicine. This is probably the most unique and unusual one that we have done. All the other ones that we have done, we've had a panel of people, and they've had a little opening discussion, and then we've stimulated some talk among people with some questions. This is going to be a little bit different. This is more of, a show and tell session, sort of at school, and what you did today. We've asked 3 of our physicians to bring with them photos, videos of some of the innovative things that they do at work, and to be able to show you. We're going to have them come up one by one, and then we'll have them all come up afterwards for questions. We're going to pass out some cards, and those of you that have been here before know how this works. In order to maybe get it to as many questions as we can that people have, if you can just write down any questions that you have at any time during the presentations today. Raise your hand when if you have a question, and we'll have somebody come around and pick it up for you. And I'll try to get to as many questions later when we get to the panel discussion as we can. So I want to get started, and we're going to start with our first panelist, Dr. Hal Frazier. Hal is the Director of Urologic Oncology and a clinical professor of urology at GW. And urology has been sort of in the forefront of some of the newer and very, very innovative techniques that have been used in surgery over the last probably 6 to 10 years at this point in time. Some of this stuff is amazing, some of it is exciting, and I'm not going to steal his thunder. I'm going to ask Dr. Frazier to come up and show you what he's been doing and what he intends to do in the future. Hal, why don't you come on and get us started.
Thank you, Dr. Wasserman. Well, good evening, everyone. Welcome. It's great to be in front of such an august audience. So I'm going to talk very briefly on what we've been doing in urology. It's been a great, exciting time for us, sometimes a little scary because we have been pushing the envelope. But we're going to focus on the robotic laparoscopic techniques that we have developed, not only here but elsewhere in the country. We've certainly pushed the envelope here. We've done a lot of the first here in Washington between the first bladder surgery, prostate, kidney, reconstruction surgery within the urinary tract. So we've actually been trying things, and we actually have done a couple of cases last week that were the first ones in that particular arena. So it's been one of those opportunities, been rare, but a lot of fun and challenging as a surgeon, and has benefited the patients. What is laparoscopy? Well, many of you may already know this, but surgery historically has been done through open technique, where we open the belly, we cut it, and we open it. With laparoscopy, we're operating through teeny incisions about the size of your pinky, and sometimes smaller, depending upon what ports we're using. We operate on a video screen. It's 2-dimensional. We have hands outside the body. We're operating up and down, left and right. We can rotate. And anything that we've done where we've translated from open surgery to laparoscopy, we've seen significant improvements in blood loss, pain control, recovery time, and recovery getting out of the hospital. So examples have been gallbladder surgery, appendectomy, hernias, GYN surgery, kidney surgery. But what we found that the pain is much less. There's shorter hospitalization. The disadvantages, however, have been that it is 2-dimensional, and because of that, you're kind of guessing where the depth of field is frequently. You learn that with time. But it's like working a video game where you're playing on a 2-dimensional screen. How many of you have ever operated in a 3-dimensional where you've actually played a game that's 3D, where you put a hood on? Or how many of you have gone to a movie that's 3-dimensional? The experience is different. Would you not agree? And a lot of the games and so forth now that are being developed, I was just talking to Dr. Wasserman, my son's interested in gaming, and they're going into the 3-dimensional world for gaming technologies. But with the 3-dimensional view, we can now see things better. Our depth of field is better. And the next level laparoscopy occurred when the Da Vinci robot was available. Instruments move like hands. In laparoscopy, you can go in and out, left and right, up and down, and you can rotate. It's what we call pronation, supination. But with the robot, we can now use wrist. We actually have fingers and wrist on the end of it that more mimics the human hand. Three-dimensional visualization. How many of you have ever seen the movie Inner Space or Fantastic Voyage? You know where people were miniaturized and they're floating around in the body. Well, I frequently, at least once a month, I'll stop in the middle of a case and I go, this is so cool, because you really do feel like you're down inside. And our head's in a hood. I'm going to show you some examples of this. You see a full three-dimensional view that's magnified tenfold, and you frequently will be looking at this small little specimen, but it's magnified tenfold, so it looks like a boulder, like you're in an Indiana Jones movie. It's precise. There's scaling. All surgeons, no matter how good we are, if they're honest, will tell you they have a little bit of a tremor. We all do. As we operate, as we fatigue, as we drink coffee, and the robot actually eliminates the tremor. The wrist closely approximates the human wrist. Instrumentation is very small. It looks like they're actually smaller than a dime in their size. We have 2 light sources and we have 2 cameras. The cameras then feed the video input into your computer and your headset, and then it gives you a three-dimensional view through computer mapping. And we actually have to set that up before we start operating. There's a camera arm, instrument arms. You have a three-dimensional viewer. This is actually one of the original robotic panels. We now are in the 3rd generation, and it's changed a little bit from this. But you have your hand controls in the middle. You have the foot controls in the bottom. You feel like you're playing an organ, where both hands are going and both feet are going. On the left and right side, you have the master control panels. And then if you look in the surgeon's console, down inside are the masters. The foot pedals are on the bottom, and there are 4, 2 on the left, 2 on the right, and then a middle one that you can focus. And then these are actually the things that control the instrumentation. They're called masters. Your hands go into there, your fingers go through what are finger cots, and then the robot approximates what your hands are doing. So we can play the video. This is just a very brief show of what it looks like. Your head is in the hood, your complete visual field is consumed by the visual input, and you're operating as your hands are moving down below. Here are the hands at work. And here's the robot at work. So as the surgeon is operating, the robot is mimicking what's going on, but through instrumentation and computer interface through a fiber optic cable. So you can see the hands are in one position, the robotic hands are in a similar position. With each generation, we're now in the 3rd generation of this robot now. We just purchased 2 new 3rd generation robots. The instrumentation is a little bit less clunky. The original ones were more clunky. Now they have a little bit more seamless. They were originally built with pulley and rotational lever action. Now it's piezoelectric motor action, so the technology continues to improve. Location of surgeon can be in the same room but on the opposite side of the room. It can be in another room across the hall. It can be across the street. And we've actually, when I was in the military, we did surgery transatlantic, where we worked through a fiber optic cable, where we did surgery in Germany on dogs. What we tried initially was a hookup through the satellite link up, and the baud rate was too slow. We found that we had to use it through a communication using a fiber optic cable. Otherwise, it was way too slow to communicate adequately. Again, a different picture. This is the surgeon could be anywhere. Now, in urology, we've done all these operations. It's expanded into the cardiothoracic surgery arena, GYN surgery, ENT, general surgery is now starting to do work in this arena as well. But in urology, these are all the different operations that we have done. We work through laparoscopic ports, which the silver ports are about the size of my pinky, and the brown or the gray ports are about the size of your index finger. We've actually even worked with single port, which Dr. Vizier is going to talk about it a little bit, and we've had to use some computer modifications to accomplish that. Here's the robot all dressed up and docking to the ports, and this is part of an operation. And the most common operation we have done is prostatectomy. We've done about 1,500 of these now, but we actually have to operate and drop the bladder to get to where we need to operate. So we develop what's called the retropubic space. As we open the retropubic space, we have to open a fascia called the endopelvic fascia, which is deep in the pelvis. And you can see the instrumentation are angled. We can move them around very much like a wrist. Probably the biggest thing the robot does that aids us is performing laparoscopic suturing. Anyone who does any laparoscopy will tell you one of the most difficult parts of laparoscopy is the suturing technique. With the wrist in there, it makes it a lot easier. For instance, how many of you have ever broken an arm and you've been in a cast and you can't move your wrist? Have you tried to do things with that? It's very difficult. And that's the way it is sometimes with laparoscopy, whereas here we can actually achieve very good manual dexterity with the articulating wrist. We're dissecting a bladder off a prostate on the left, and on the right we're dropping what's called the dorsal venous complex. And then you can do sharp and blunt dissection. You can either sharply or blunt dissect on the left or actually cut on the right, depending on the instrumentation we're using. And mind you that prostate here is quite small. It looks quite magnified here, but it's a lot smaller. It's about the size of a walnut. And then this is an example of the specimen being collected. And this can be anything. It can be a gallbladder, it can be a kidney, it can be a tumor in the colon, and in this case it's a prostate. The fine suturing here is tremendous. We can do plastic closures with UPJs where we have obstruction in the kidney. We can put together the bladder and the urethra. They can do bowel surgery with this, and the suturing is a really incredible part of this. It adds a lot to the operation. So we can do plastic closures with the technology. It's less invasive. The vision is definitely better. It's three-dimensional, magnified, less blood loss consistently, and that has to do with the laparoscopic approach. We do see improved visualization of the vessels and nerves, and it is more precise. The question is, are we getting better functional outcomes? We can talk about that a little bit later. Thank you very much.
Well, some of this stuff really gets amazing when you get a chance to see it, and I mean, especially when you get to see it every day. We're going to move from surgery over to medicine a little bit because we want to give everybody a chance to have their say and to show you a little bit. And for that, I've asked Dr. Mazzari to come up and talk to us a little bit about cardiac catheterization and some of the new techniques there. Now, let me just tell you a little bit of a story. I think it was about 18 months ago, maybe 2 years ago, I'm not exactly sure. The Washington Post actually ran a little story in the health section of the Washington Post about Dr. Mazzari and her technique, which was unique to the Washington, D.C. area at that time in doing cardiac catheterization through a little pinhole incision in the wrist. Up until that time, all the catheterizations and angiography that was done from the groin. Large incision, large vessel there. Patients after the procedure had to stay at bed rest for a long period of time. I'm going to let her tell about that. But after this came out in the Washington Post, the next week there was article, letter to the editor after letter to the editor from every other hospital around the area saying, this is gimmicky, nobody should do this is dangerous. Well, if you've listened to the radio in the last 3 to 4 months, every hospital in the area is now touting their radial artery approach to cardiac catheterization. No more is it gimmicky, no more. Now they're all jumping on the bandwagon 18 months later. So it's a pleasure to introduce Dr. Mazzari, an assistant professor in the Division of Cardiology, to show you and tell you a little bit about this technique that she's brought to Washington, D.C. Ramesh?
Thank you very much, Dr. Wasserman. Good evening, everybody, and thanks for being here. I'm an interventional cardiologist at GW, and my passion is to treat patients with coronary disease. So a procedure that I commonly do is coronary angiography and angioplasty. That is one of the most common procedures done in the United States. 2.5 million cardiac catheterizations are done in the US every year. And It's a procedure that examines the blood vessels in the heart. It's the same procedure we use emergently to treat patients who are having a heart attack. And there are two ways of doing the procedure, as Dr. Wasserman mentioned. The conventional approach is to create a small insertion into the femoral artery that is a big artery deep in the leg, and cannulate the artery and use wires and catheters that will eventually reach the coronary arteries in the heart, and take a picture, and if necessary do procedures to open up the blocked arteries. The second a minimally invasive approach would be to use a much smaller artery in the wrist called radial artery, and basically choose more of an unpredictable, perhaps tortuous path, but eventually reach the heart and do the same procedure. So the conventional approach is easier to do compared to the radial approach. But 7% of these procedures can be complicated by bleeding. This is a very big artery, and bleeding from the femoral artery could be fatal. On the other hand, the radial approach would be much safer because we're working with a much smaller artery that is very easy to compress, and the risk of bleeding would be minimal. So this approach is elegant, safe, patient-friendly, and cost-effective. The recovery from this procedure would be much easier compared to the procedures done from the femoral artery. And despite that, of all the 2.5 million procedures that are done in the US, only 10% of them are done using the radial artery. After the article in Washington Post was published, one of the producers of a program called Next Generation on PBS was interested. So they came and spent a day with us in the cardiac catheterization lab. And they followed 12 patients who had the procedures done femoral and using femoral in the radial approach. And thanks to Andrew, the producer, my talk is very easy because I have a piece that I would like to share with you. And it's the experience of 2 of our patients, and it's a real-time comparison of the patient's experience and especially the recovery after the procedure. So we'll play the video.
As a concert pianist, David Ehrlich can't risk hurting his wrists. So he was anxious when a cardiologist took an emergency look at his diseased heart with a catheter, not through the groin as he expected, but with a small wire that entered through an artery in his wrist.
Shouldn't feel anything else.
And how did that affect his playing?
0. Absolutely not at all.
Ms. Gordon, I'm going to give you some numbing injections here, okay? You may feel a little burning.
Dr. Ramesh Mazhari is one of the very few American doctors who prefer heart catheterization through the wrist.
Slight pressure going in.
Most doctors do it through a much larger femoral artery deep inside your groin. Dr. Mazhari thinks the radial artery in the wrist is better.
It is safer and it is more comfortable for the patients. Here you see the catheter entering the common femoral artery.
TV medical shows make unblocking clogged arteries appear safe and routine. After all, doctors do 1 million of them each year, but they are not risk-free.
One of the most feared complications of doing an angiogram using the femoral artery is the bleeding complication. Bleeding can be very serious sometimes. Some patients will require blood transfusion, and it could be fatal.
No, it's fine. I can just get on the other side.
The other issue is patient comfort.
If you're not sleepy enough, let me know.
Okay.
Okay?
I usually want to feel pain.
We don't want you to feel pain.
Elvia Gordon will get her catheterization through her larger femoral artery. She won't feel pain, but the recovery will take a while. And she can't move for a half day afterward to ensure the artery stays closed.
No tenderness, no pain. So you have 1 more hour of this, and then we can gradually get you out of bed. The advantage of this approach is that right after the procedure, you can sit up and walk around.
Mary Lynch got her catheterization through the smaller radial artery in the wrist.
She sits out, the balloon is fully inflated.
The recovery was so fast, she was up and smiling immediately after surgery.
I'm ready to go home. I feel good. I don't have it. There's no pain. Doing the surgery, I just feel the doctor's hand on mine, but I didn't feel anything else.
Cardiologists wanted to know the difference between the two procedures, so they studied hundreds of patients. And what they found was remarkable. Nearly 60% fewer bleeding complications when they went in through the wrist.
With the radial approach, we're using a much smaller artery that's very close to the surface. It's very easy to compress, and the risk of bleeding is minimal.
While going in through the wrist is more comfortable and has a quicker recovery, it's not always the best way straight to the heart. If you've already had bypass surgery, it's often safer to use the femoral artery through the groin. Doctors recommend kidney patients use the femoral too, and going in through the wrist takes a lot more practice.
Using a radial artery could be very challenging. There are anatomic variations that are unexpected, and you just have to learn the new techniques and tricks to overcome the obstacles.
And in the cath lab, time is money.
It took me almost 100 cases before I felt very comfortable doing this procedure. Physicians are very comfortable doing the procedure using the femoral artery, and they are reluctant to learn a new technique.
Some patients wish they would. Mary Lynch's doctor discovered severe blockages and will be back for bypass surgery. But this quick trip to her heart may have saved her life.
I think it's a second chance at life, it is. So I get it done, go home, get back to real life.
And our concert pianist, his wrists are fine, as well as his heart. The catheterization discovered blocked arteries, and a bypass operation is keeping him playing concert halls into his 70s. David offers his doctor a heartfelt thank you. In Washington, I'm Andy Field for My Generation.
And for the reasons that were mentioned in the movie, it is now the default strategy in our cardiac catheterization lab at GW to perform radial procedures, even in the setting of acute myocardial infarction. And we believe that a safer and a much more comfortable option should be what we offer the patients. Thank you.
Now, since many of you have been here before, I assume you all know that acute myocardial infarction means heart attack, right? I don't have to explain that, right? So I don't want to have to say these things twice, so make sure to pick that up. Could he play the piano before the procedure? Or I had to get that in. I mean, somebody's gonna ask that. And the announcer better lose some weight, otherwise he's gonna be on the cath lab also. Okay, so we went to surgery, to medicine. Now we're gonna go back to surgery. Dr. Kay Mazzari is an assistant professor in the Department of Surgery. He's the director of our surgical clerkship program. Kay finished up his surgery residency at GW, and I wanted his wife to be my chief resident for a year, so we sent him away to Chicago to do a fellowship in minimally invasive surgery at Northwestern so she could be my chief resident for a year. And then after that year was up, we let him come back, and he's been at GW ever since, and he's going to show you some really neat things that he's been working on and tell you about some even more amazing things. Kay, come on up.
Thanks. Thank you for having me. It's nice to be here. Dr. Fraser's already shown you some of the stuff, kind of end of the road, what the future is, and we'll get to that at the end of this talk. What I'm going to do is kind of take you through where we've been and where we're going now through anti-reflux surgery. Anti-reflux surgery, of course, is an operation for heartburn. So the best operation for heartburn is called a Nissen Fundoplication. And this is just a schematic showing the esophagus, which is the muscular tube that connects the mouth to the stomach, and it goes through the diaphragm, which is the breathing muscle. There's a natural hole there. At the very bottom of the esophagus, where it connects to the stomach, there's a natural one-way valve. When that one-way valve doesn't work correctly, the harmful acid from the stomach can go back up into the esophagus, and we all get heartburn. Now, that happens to all of us from time to time, but when it's severe, you can do an operation called the Nissen Fundoplication to get rid of this reflux, and that's basically taking the top of the stomach, called the fundus, and wrapping it around the bottom of the esophagus, surgically recreating that one-way valve and preventing reflux. Now, as you can see, it's a tight spot to get to. You're kind of right at the bottom of the chest and right at the very top of the stomach, so what's the best way to get there? Well, when this operation was first invented about 20, 25 years ago, there was a thoracic approach, meaning through the chest. You'd come in and they'd make an incision, as you can see here. This is a healed incision, through the chest, put in some rib spreaders, and push the lung out of the way, get to the very bottom of the chest, right where the breathing muscle is, and wrap that stomach around the esophagus. After surgery, you're in the hospital maybe 4 or 5 days. You can see there's one large incision. There's 2 smaller incisions because you need some tubes placed in your chest to re-expand the lung. And after about 4 or 5 days, you get that taken out and you get to go home. Now, I do this operation, and looking at that bottle of Tums doesn't look that bad anymore to me, and I think I just might deal with my reflux. So they thought maybe we'll go through the abdomen. We'll go through the abdominal cavity and get to the top of the abdominal cavity, just kind of coming at it from the other way. So this doesn't project very well, but the abdominal approach classically was done through a big up and down incision right here in the middle of the abdomen. And if you were to walk in any operating room where there's a big open procedure, you'll see something like this. 5 or 6 people all huddled around, staring through a little hole. No one really can see very much, and everyone's trying to get the best angle on it. So that naturally evolved into the laparoscopic approach. And the laparoscopic approach, as Dr. Fraser has gone through, is making a couple little incisions. And for this operation, it's 4 or 5 little incisions, the largest of which is 1 centimeter, which is less than ½ an inch. And most of them are about 5 millimeters, so smaller than the diameter of your pinky. We use a laparoscope, which has got a light and a camera on one end, and it projects onto a TV screen, kind of like playing a video game. The nice thing about that is that we get to see much better. And before surgery, the patient comes in, nothing to eat after midnight. We make a couple incisions, do the operation in about an hour, hour and a half. You're in the hospital overnight, you go home the next day. No tubes, no drains, no lines, no big incision, no rib spreaders. And you're at home, maybe a week off of work, because you can get a week off of work. And come back and see us in about 2 weeks. Now I'm going to show you a video of this laparoscopic approach, and I can show you the advantages. Now here's just a general view. Here's the stomach. Here you can see the diaphragm. We're underneath the liver, and you can see how tiny this area is, but how magnified it is for us and how easy it is for us to see. And basically, what we'll do, this is the diaphragm, which is that breathing muscle, and you can see the stomach here. Now the esophagus comes through this diaphragm right about here, and it connects to the stomach. And this is where we're going to recreate that one-way valve. We use thin instruments, and this is called a harmonic scalpel. And basically, to give you a reference of how large this area is, if you look at the silver tip of this instrument, that's about 1.5 inches. So we're really magnified. And you can see with our HD monitors, our high-definition monitors, because we should do everything in high definition as far as I'm concerned. We can get in here, and you can see the esophagus right here coming through this breathing muscle. Stomach is going to be down here. And as we get up into the chest, now remember, we're in the abdominal cavity, and we're operating up into the chest. We need to free up that esophagus, get it down out of the chest so that we can wrap the stomach up around it. Here you can see a better picture of the esophagus. This is the diaphragm. Again, we're working almost like under the hood of a car. The entire left portion of the liver is above us. So we're really in a tight little hole. Spleen is back here in the background. Okay, and you're going to see some pretty big structures in a second. One is the main blood vessel called the aorta, which is a blood vessel probably the size of a garden hose. That brings all the blood away from your heart. Next to that, you'll see in a second, is the vena cava, which is a vein about the size of a garden hose that takes blood back to your heart. So again, a very gentle dissection. We get the esophagus all cleared out. Back in that hole, you're going to see lung. Okay, and we do not get into the lung cavity, so we don't need any kind of tubes or drains or something. But as you can see, through a couple little incisions, we can really get that esophagus, which is right here, really nicely mobilized. There's the aorta right there, that structure that the sucker is right on top. And as you can see, the little markings on the sucker are 1 centimeter. So you can see how close we are. Here's some laparoscopic suturing. As Dr. Fraser mentioned, this is probably the hardest skill to do laparoscopically. And we reapproximate this diaphragm. Once the diaphragm's closed and we cut that stitch, this is the part where the fundoplication happens. This is called the Shoeshine Technique because it looks like you're shining a shoe. And what you're doing is basically that's the stomach in both those graspers, and you wrap the stomach around the esophagus, which is right here in the middle of the screen. The way we fix that is with a couple of stitches. We put a bougie down, which is just basically a tube that goes into the esophagus to make sure that the wrap is not too tight, because you don't want to make it too tight. You want the one-way valve to be perfect. We get the bougie down. And then, again, we'll use suturing. So this is just sewing. And these instruments that you see us using are about 40 centimeters long. So you are never actually touching the patient. You're on instruments, and the instruments are about the length of your elbow to your index finger. So all the operating is occurring about 2 feet away from your hands. And again, very magnified, which allows us to be very precise. And you can see with the stitches, the stomach is being wrapped around that esophagus, and it's going to recreate that one-way valve. Again, the whole thing is occurring underneath the liver, a very difficult place to visualize, and that's why you see all those surgeons huddled around that incision, trying to look underneath the liver, way up in this corner of the abdomen. So this is a difficult technique. The robot makes it easier with the wrists, as we don't have wrists in straight laparoscopy. And this is a procedure that is done robotically. Here's the finished product. Again, spleen over here, happy. You can see the stomach wrapped around the esophagus, recreating that one-way valve. And this effectively will eliminate the reflux. And your soft food overnight, and then you go home. You get to beat the rush hour traffic the next day. But that wasn't good enough. So the next step is, well, can we do this without any incisions? That operation, I showed you through 5 incisions. We can do that with 5 incisions. We can do that operation with 1 incision. We can do that operation with the robot. But that's not quite enough. And the next step would be, well, can we do this operation from the inside of the stomach with no incisions? An endoscopy, just like a colonoscopy, an upper endoscopy is an endoscopy with a flexible tube that goes down through the mouth into the inside of the stomach. There's a procedure called a transoral incisionless fundoplication. Again, fundoplication means wrapping the stomach up around the esophagus, where it's all done from the inside with an endoscope. So there's no incisions. It's just like getting your colonoscopy. You got to drink the stuff the day before. You come in, you have the procedure, you go home the same day. There's no incisions, there's no pain because everything's done on the inside. Here's a cartoon. You can see the endoscope being passed down through the mouth, just like you would have an endoscopy for anything else. There's a light and a camera on the end. There's a mold that's folded back. Now, this is the stomach. You bring your scope in. You flip the scope back on itself, so you're looking back up at the junction between the esophagus and the stomach. You have a little you track the fundus with the little corkscrew into the mold. The mold closes, and it basically shoots a little fastener like you see on the clothes that you buy at the mall. That little eye fastener, a little plastic fastener, and what that does is it fixes the stomach to the esophagus, creating that wrap. You start in one corner, then you rotate, and you do the same thing, and you can recreate that valve 270 degrees, all in an outpatient procedure. Same thing. The corkscrew goes up, pulls the stomach down. The esophagus is on the other side of this. You shoot the eye fastener through, and you have your fundoplication. It's a 270-degree fundoplication as opposed to the 360. The benefits are outpatient procedure, no incisions, no pain. You're home the same day. That's all I have for you.
When do you ever think you would hear a surgeon say, "We never want to touch the patient"? It's just amazing and really hard to believe. I'm going to ask our panelists to come on up now. And again, if you have any questions, please write them down. Just raise your hand, and there you go. We'll get some of the questions up here. Before we come on up, before we start though, I'm going to ask Dr. Mazzari to come up here and show you one last thing while we collect some questions and before we get started. And that is, Dr. Mazzari just showed you how to do something through the stomach without making any incisions. Well, I don't know, her, not you.
Okay.
I don't know whether you can even imagine replacing a heart valve without making an incision, but that's what we're going to show you right now. Ramesh?
So as Dr. Wasserman mentioned, one of the most exciting developments in the last few years has been the minimally invasive heart valve surgeries. Aortic stenosis is narrowing of the aortic heart valve. 300,000 patients in the United States suffer from aortic stenosis, and it's a fatal disease. And a third of these patients cannot have the conventional treatment, which is open heart surgery and replacement of the valve. We have recently, the FDA has approved a minimally invasive catheter-based, we can play the video, a minimally invasive catheter-based approach to replace the valve without open heart surgery. we use the common femoral artery that we talked about. I don't like it for coronary angiogram, but I do like it for replacing the valve. So cannulation of the femoral artery in the leg is performed. Large catheters are placed in the artery, and we use basically catheter-based balloons that will modify the very angry, calcified, tight aortic valve first, and then there's a prosthetic aortic valve that is loaded on the catheter and will eventually be advanced all the way up across the valve and will be deployed to replace the diseased valve. So all it takes is a big hole in the artery in the leg and no incisions in the chest. The recent studies have shown that this approach is as good as surgery for patients who are very high risk for having this big operation done. And it's one of the most exciting developments in the last few years. Here's the valve that's being deployed across the valve. It's a balloon expandable valve. The balloon expands the valve, and the balloon is basically removed, and the valve will stay in place. Great, thank you.
This used to be a death sentence. When you had a very tight valve in your heart like this, if you couldn't have open heart surgery, there was no medical therapy for it. This is just an amazing, amazing thing. And this is only the first valve that we're going to be fixing without incisions. We're going to be fixing other valves the same way. And it's not going to be long. Our goal is to put the cardiac surgeons out of business. And we're trying as hard as we can to do that. Kay, one of the things that we've talked about over the years is if you can do this thing you showed us through the stomach, why can't you do more through the stomach without making incisions? Why can't you take out kidneys and things like that? Is that ever going to become a realization?
I think so. I think so. I mean, some of it's already been done. I was involved in some of it. And something I hope to bring to GW soon. I have a video I can.
You really? I didn't know that.
I have a video I
Full
can show you.
surprises. Okay.
Can you cue up my last video? So this is really, I think, where everything is going. This is called NOTES. It's Natural Orifice Transluminal Endoscopic Surgery. It's the same idea of using the endoscope to do intra-abdominal operations. Now, the reflux operation was an easy one because, well, we're inside the stomach, and I can wrap the stomach because I'm on the inside. But how about taking the gallbladder out through someone's mouth or through the stomach? This is actually something that we've done, and here you can see an operating endoscope. It's the same thing that we showed you, but at the end you can see there's 4 channels. And through these 4 channels you can get your visualization, you can get instruments. Now this is a big effort, and you can see how many of us are in there trying to do this one procedure. It takes an endoscopy team, and for safety we're actually using a laparoscopic port for the first 4 of these that we have done to kind of show that it can be done safely. And here we're inside the stomach. And you can see that we're making a hole in the wall of the stomach. So basically we make a hole in the stomach to get out into the abdominal cavity so that we can get to the organs other than the stomach. Once we make a hole, we slide a balloon, kind of like the balloons that are used to balloon endovascular things. It's a 20-millimeter balloon. And here you can see an outside shot for safety. You can see the balloon, this is the stomach, and now we're outside the stomach and there's a balloon here. We balloon open the hole in the stomach in order to allow this operating endoscope. Now remember, the other end of this blue endoscope is coming out of the patient's mouth. We look back and we find the gallbladder, and now we're using instruments through that endoscope to do gallbladder surgery. This is a different view than we see laparoscopically. It's totally upside down. It's very difficult, and as you can see, we're very limited by the movements of the instruments. It's all right down the barrel. You can only go in and out. You can't really go sideways, and it makes it very difficult to do. That being said, it's being done successfully. We've done it successfully on humans, and it's being done now worldwide for a variety of different procedures, all under a research kind of protocol. But this is where things are going. And you can see here's the gallbladder at the top of the screen. The dissection is done. You're controlling the bile duct and the blood vessel to the gallbladder with these clips. And just like we would do in an open operation, just like we would do in a laparoscopic operation or a single port operation. And once you control the bile duct to the gallbladder and you control the artery, you can cut it and take the gallbladder off. Now you can see that the screen is flickering because remember we're operating through an endoscope. It's kind of, sometimes there's a little bit of fluid on the camera. It's really difficult to kind of see. But this, again, is a procedure in its infancy. And this is really one of the first operations done on humans. And you'll see here's the gallbladder, and we're going to take the gallbladder off of the undersurface of the liver, which is what you're seeing in the background. And once we get the gallbladder off, then it's a matter of getting it out. So here's the completion of the dissection. There's the liver in the background. The gallbladder is coming off the liver. That last little bit. And again, you can see us operating right down our field of vision. Now we've grabbed the gallbladder, and we're going to take it back through the hole in the stomach. We leave a wire through the hole in the stomach so we can find it, because we got to close it. We can't leave a hole in the stomach. So we grab the gallbladder, and we bring it to the inside of the stomach. We back our scope up, so now we're inside the stomach. And what we got to do is we got to close that hole. So we use this device here, and kind of the same corkscrew device. You can see the wires going through the hole. We corkscrew some tissue. This G-Prox device, once you grab the stomach, you pull it back into the jaws of this device, this G-Prox device. And what that device does is it pinches the tissue, it shoots a suture through both walls, and it deploys a basket on one side. And then you back the needle up, and it deploys a basket on the other side, and you cinch the two baskets together, closing the hole. Looks pretty simple. Not simple to do at all. It's actually very difficult. A lot of times you're upside down or backwards. Then when we're all done with the closure, and you'll see how the stomach's closed in the background, we grab the gallbladder. Again, we're inside the stomach now, like a regular endoscopy. And we pull it back up through the esophagus and out through the mouth. So you have 0 incisions. You don't have much pain at all. You have 1 night in the hospital when you go home. And here you can see the gallbladder coming out through the mouth. So this is just an example of one operation, but if we can get into the abdominal cavity with an endoscope, then any organ that's in the abdominal cavity is fair game.
How vain do you have to be not to want to have a little tiny incision to have your gallbladder taken out? This is not, of all the things we've shown tonight, this is not ready for prime time yet. But, you know, don't be surprised. These things, you know, we thought some of the other things you saw tonight weren't going to be ready for years and years, and this thing is moving pretty fast. Hal, one of the things people are concerned about, and I guess everybody should be, and you mentioned it, is outcomes. And the major outcomes people are concerned about usually with prostate is nerve function. Are they going to maintain sexual function? Are they going to maintain bladder function because of nerves? So how good is the robot compared to standard open procedures for preserving nerve function?
That's an excellent question. When we do deal with prostate cancer in particular, the first goal here is to take care of the cancer. You know, we want to make sure that we cure them of their cancer first and foremost. So the success rate with the robotic technology is equal to the open surgery. Early on, there were problems because we were still learning how to use it to our advantage. But now it's equal to, and in some hands, certainly in our experience here, our margin positive rate is lower with the robot than with open surgery. With the other two functional outcomes that we worry about, are they continent? Are they leaking urine? Are they dry? And are they potent? Are they able to have erections? With continence, the continence rate's about 94 to 95% are completely dry by 3 months. 4 to 5% have a little bit of leaking when they cough or laugh or sneeze, and about less than 1% have leaking where we have to do something about it. People ask me, well, why does that happen? There's a muscle underneath the prostate that keeps you dry when you're 15 years old. As the prostate enlarges, it actually starts to squeeze the tube that you pee through, acting like a sphincter. The muscle sphincter grows lazy. You remove the prostate, and that is a problem because that muscle is now lazy. It hasn't been working hard. So we teach people to do Kegel exercises. And with robotic technology, we're very good at able to bring that back to normal. The third issue is erections. And we really thought this technology would help us a lot with the erections. That was our goal. And we're finding that that's still a black box. We're not curing as many people with cancer and preserving erections as many as we had hoped. We can definitely see better. You saw it on the video. We can see the nerves much better. We're hoping with the newer technologies and what we worry about is burning. If we use hot equipment or electronic equipment around the nerves, it can burn the nerve. And there are some series that show that if we do rehabilitation with Viagra or Cialis or Levitra, that we are seeing improved outcomes. But for the most part, the robotic technology, although we would hope would be a lot better, is minimally better, but it's not the home run that we were looking for.
You know, we've talked about treatment, and that's what our focus is here tonight, but we have another mission I think people know at the university, and that is teaching. And it would seem to me that my question would be, if I saw this, is you're really working in small spaces, even smaller now than when you made open incisions or when you used the femoral artery, which was larger. How are we going to teach the next generation how to do what you people are doing when you're so limited in your vision?
It's a great question. It really is. I'd like to, one issue that we were talking about, some of the kidney surgery that people have been performing laparoscopy through a single port and then taking the kidney out through a vagina. Now, men don't have a vagina, so that can only be used in half the population. From the teaching standpoint, I do find it's a real challenge for us, and we do worry about that. I do find, however, as I've taught people my generation who are in their 40s and 50s to operate on the robot, they have a longer learning curve. It takes them a lot longer. Whereas if I start working with a resident or a fellow who's grown up, what we call, their digital generation, they've grown up playing video games. They know how to work on a screen, and they know how to work that audiovisual hookup. They learn much faster than I did, and much faster than my colleagues that are my age. So as I work with residents and fellows, their learning curve is much quicker. In fact, I have one of our graduates here who really picked this up very quickly, and I just find it's a lot easier. It's a big question, though. The third generation robot that we have has a teaching screen on it where we can actually touch on it, and the person in the hood can see where we're touching, and we say, no, don't go here, cut here. So the learning process is even faster because of that.
Yeah, and I think from an educational standpoint, simulation, surgical stimulation with the dry lab, the animate lab, we have a WISE center here where our residents go and even attendings go to practice laparoscopic suturing, to practice these techniques on inanimate objects. And there are also animal labs that are put on as teaching labs to practice these techniques and troubleshoot so that it's not your first time when you're assisting one of us in an operation.
When we first started doing the robotic technology, we were the first people in the area, so we didn't have anyone other than ourselves to work with. Now with the concept of simulations, pilots spend hundreds of hours in the simulation lab before they ever get behind the back seat or seat of a plane. And we now have robotic simulators where people can practice. And so we are hoping that will shorten the teaching process as well.
Is there a major difference with cost with any of these procedures, and does Medicare cover all these procedures, or are they looked at as experimental, or?
The robotic technology now is covered by every major insurance company, but they don't pay any more than a laparoscopic technique. So the hospital is the one that has to eat the difference in the cost. It is a lot more expensive. The robot costs about $1.5 million, and then they have to pay between $100,000 and $150,000 per year for maintenance. So it's a very costly endeavor. The hospital, though, is willing to invest in it because they see it as the future.
But does the hospital make up money, though, on the decreased length of stay? And are we pushing the length of stay too short? Are we worried about that, getting people home too early?
Definitely length of stay is shorter, and that's where the hospital makes up the difference. The OR costs are more expensive. It's about $1,000 to $1,500 more per case. But then on the other side, at the end, when people go home a day or two earlier, they save in that particular cost.
Okay. Ramesh, let me start with you and ask each one of you to comment on this. How often do you have to switch gears and go from one procedure to the other? How often do you have to go from the radial to the femoral?
When we started doing this 3 years ago, we had almost a 15 to 20% conversion rate. But as I said, it's like anything else, you do enough of it, you get really good at it. Right now, rarely So there's definitely a learning curve, but after doing a few hundred cases, I think
And selecting the right the right patient to have it done. Also, I would imagine are there some people that just shouldn't have the radial? You mentioned a couple, but what about people that don't have good pulses in their hands or?
Yes, that video is about a year old. Since that video, we have been doing patients who had a cardiac bypass surgery, so that's not an exclusion criteria anymore. But patients who are very sick and are requiring medications to keep their blood pressure up, which would cause narrowing of the arteries, and the arteries are clamped down, will not be good candidates for the radial approach. And that's really the only thing I can think of now.
Okay.
Yeah.
Okay, what about how often do you have to go from laparoscopic to open?
Yeah, my conversion rate, or our conversion rate here, is actually very low, maybe 1% of the time. And I think you touched right on it. It really has to do with patient selection. There are patients that may not, that a laparoscopic approach is not the best approach because the conversion rate will be very high. For example, patients that have had that specific operation or an operation in that area before. Though most of those we can get done laparoscopically, but those would be the patients that are slightly higher risk for a conversion. But all in all, it's very low, maybe probably around 1 to 2%.
And how I would imagine that it would be no easy feat to convert from a robotic in the middle of surgery to an open when you have a big machine over somebody, but does that happen?
In our first 1,000, we had 3 conversions, and they were all in the first 100 patients. We've not had a conversion since then, and we're pushing over 1,500.
Yeah, I think that gives everybody a sigh of relief. This is a great question here. If you're not over the patient, why are you all wearing masks in the operating room? I love that question. So,
we try to keep the operative theater as sterile as possible. You know, your germs are your germs, and if you get some skin infection from yourself, it usually doesn't cause as much of a problem as if I give it to you, if it's a germ from my body. So we're very careful about making sure that our hands are clean, that we're covering our face. It's just a sterile technique that we have maintained, even if we're a distance from the patient. The whole room is maintained to be sterile so that we minimize the risk of the patient. And honestly, even in spite of that, we still occasionally have wound infections, or we might end up with somebody with a blood infection. Again, that is very rare. We just published, actually our paper was just accepted for our first 1,000 patients, and we had about a 2% wound infection rate with the robotic technology. It's never been major, and we've never had to go back to do anything other than put them on antibiotics, but it's still an issue.
You talked about using the robot for prostate for men. What about for women? Are there specific issues that can be used for bladder surgery? And
we do kidney surgery on both sexes, obviously, bladder surgery on both. We also have been doing quite a few sacral colpopexies. That's where the whole pelvis is dropped as women age, especially women who had childbirth. The pelvic floor has been stretched out, and it just doesn't have the ability to hold it in position anymore. So we can do what's called a sacral colpopexy, where we're actually pulling all that back and tacking it to one of the major bones of the body, and it holds it in position. So yes, and we can do pelvic floor reconstruction that way.
So I assume we're nowhere near the limits of this type of technology, and is there really anything you can foresee that we wouldn't be doing through either minimally invasive techniques, either with the heart or with any of the abdominal organs?
I think trauma. I think we're still going to have a significant need for management, open surgery for trauma. In fact, the robot was originally designed by the Army. Their intent was to use it in a battlefield situation, but they quickly came to realize through the satellite link-up it was too slow, that there are just too many things that can go wrong in a trauma situation, and you can't necessarily see everything. So that is one area for sure. I think we'll continue to see open surgery. But I agree with, I think there's a great opportunity here and wonderful chance that most of what we do is going to be done through this minimally invasive technology in the very near future. Absolutely.
Yeah, and even in trauma surgery, non-military trauma, for low velocity, stab wounds, even the standard of care for stab wounds to the abdomen now, explorations starting laparoscopically is really taken over. So the minimally invasive technique is actually starting to creep into trauma also. Of course, for big gunshot wounds and big car accidents, it's still not going to have that much of a role because you need to get in there, and with all the blood, it's going to be difficult to see.
Ramesh, has the incidence of bypass surgery, open heart bypass surgery, starting to go down in this country with some of the minimally invasive techniques that we have now?
I believe so. I think that every time we compare a minimally invasive approach to the conventional open heart surgery approach, one of the major issues that will come up is the bleeding complications, because they predict bad outcome. And one of the advantages of any minimally invasive approach, especially in cardiology, is that we are reducing bleeding complications. So that, I think, would be the main.
Well, I hope we wowed you tonight. We tried to. I hope we succeeded. I hope you can see what not only the future has to hold, but what we're actually doing today and what hopefully will be done tomorrow. And if you're thinking of having surgery that we didn't mention today, hold out a little longer, and we'll probably come up with a way to do it through a little tiny incision, or no incision at all. If I haven't got to your question, I apologize. Come on up and speak to our panelists for yourselves. And thank you very much, and good evening.